next session is on stem cell transplantation, which will be done by Dr. Popat. So it will be moderated by Dr. Chandran Nair. So over to Dr. Chandran Nair to introduce the speaker as well as the panelists and to take over the session.
Thank you, Shinto, and very good morning to Dr. Popat. Good morning. Morning, and good evening to all the panel members. So it's my pleasure and privilege to introduce Dr. Popat, who is actually well known for almost all the Indian hematologists and hemato-oncologists. He is currently Professor of Medicine and also Deputy Chair in the Department of Stem Cell Transplantation Cellular Therapy at the prestigious MD Anderson Cancer Center, Texas. This is a very active researcher with more than 250 publications, and his main research interests include reduced density conditioning and allogeneic transplantation for myelofibrosis and also autologous stem cell transplantation for myeloma. And followed by his lecture, we will have a panel discussion basically on the mainly practical aspects. So, and we have the panelist, Dr. Chepsi Philip, who is senior consultant at in hematology at Believers Church Medical College, Tiruvalla. Then Dr. Mobin Paul, senior consultant in hematology at Rajagiri Hospital, Kochi. And then we have Dr. Roshan Haldar, who is consultant, Department of Hemato-Oncology and BMT, Rajiv Gandhi Cancer Institute, New Delhi. So over to you, Dr. Popat. And he will be talking on stem cell transplantation, past, present, and future. Thank you very much.
Thank you very much for the invitation. Let me share my screen, and please tell me if you can see my screen. Can you see it?
It's seen, yes.
Okay, yeah. Okay, so thank you very much for inviting me, Dr. Shinto, and the organizers. It's a real pleasure to speak at this meeting, and it's always a pleasure to talk at an event in India because it brings back some old memories, meet some old friends and catch up with them and make some new friends. My topic today is stem cell transplantation, past, present, and future. And what I thought I would do here is what I have seen during my career, changes that have happened, and what changes do I expect in what things do we expect in future. So this is almost always a personal narrative. Obviously, there are others would think it differently, but I thought I chose what I think that I've seen, things that have affected my practice, and things I think will likely affect my practice and will be of use to you. So the agenda for today is I'll talk about graft source, conditioning regimen for prior to stem cell transplantation, supportive care, graft versus host disease prophylaxis and treatment, donor source, and the diseases that are treated by this. What was past, what is present, and what is going to be future. So this is a place where I trained. This is LTM Medical College in Sa in Mumbai. You see the iconic Mumbai taxi. I think it's probably disappearing these days, like everything else. And I left after my MD in 1990 to go to UK, and I ended up at Royal Free Hospitals. And at Royal Free and other hospitals in UK, I trained in hematology and later bone marrow transplant. And what I'm going to talk about is I'll start in 1995 when I left Royal Free after training in transplant to go to MD Anderson to do a transplant fellowship over there as well. And that's the start, that's the past for me. So in 1995, our main graft source was bone marrow. We were beginning to use peripheral blood stem cells for autologous transplant, but for allogenic transplant, it was mainly bone marrow. There were basically two regimens, cyclophosphamide and total body radiation, or busulfan and cyclophosphamide. These were the conditioning regimens that were used, and one could do different iteration and doses of this, but essentially this is what we did. Supportive care consisted of standard antibiotics, but for antifungals were limited by with amphotericin. So anytime your patients develop antifungal infection, fungal infection, you started them on amphotericin, and like a clockwork, a few days later, your patient ended up in renal failure. So it was tough time in those days, and you hope that you would not get any antifungal infection. CMV used to cause mortality in about 15% of our patients. Again, cyclovir was beginning to be used as a treatment. However, as most of you know, it causes low counts and cytopenias, and it was a significant problem, because many a times, like with fungal and viral infection, it was sometimes you wondered whether the disease led to the bad patient outcome or whether the treatment for the disease led to the bad patient outcome. CSF was available, and we were routinely using it to accelerate neutrophil recovery. And as most of you know, it improves engraftment by 2 to 3 days. GVH prophylaxis was standard cyclophosphorin methotrexate. Tacrolimus, or FK506, was being studied at that time, and when I reached MD Anderson in '95, they had clinical trials, and they were moving from cyclosporin methotrexate to tacrolimus methotrexate. But essentially, calcineurin inhibitors were the main therapies. If you got GVHD, if your patient got GVHD, the treatment was steroids. And really, that was, you hope that patient would respond. About 30 to 40% of your patients would respond, and rest of them develop steroid refractory graft versus host disease, and most of the patients succumb to it. Donor source was mostly matched sibling. Unrelated donor transplant was a new thing at that time. And how new it was, I can tell you at that time in '95, my boss at Royal Free in London, which was one of the biggest transplant center in UK at that time, asked me to review our patients who had undergone unrelated donor transplants. And when I looked at it, we had 30 patients. We had treated 30 patients until then. And sadly, there were only 3 survivors. And the oldest survivor was 25 years old. So really, in those days, if you're older than 40, you were considered too old for transplant. The main diseases we treated were CML and acute leukemias. And when I moved to MD Anderson, breast cancer transplants were a new thing. That's the last thing I'll say about it. As many of you know what happened, and eventually the trial showed that this was not effective. But when I reached MD Anderson, half of our transplant case patients were having transplant for breast cancer. One of the other important things to note over here is unrelated donor transplants. Our typing was mainly serological. So we thought we were doing HLA matched unrelated donor transplant, but in practice, many of them, these were mismatched if you were to do high resolution typing. So this was 1995. And here I ended up at MD Anderson. And here I'll chronicle the progress from 95 to 2022 in next 10 or 15 minutes. So first was the source of stem cells. We started in the OR like this, harvesting the marrow, which we still do. And to some extent, that is still a preferred choice, and we can discuss about it where I would consider bone marrow as opposed to peripheral blood stem cells. But when I reached MD Anderson, we started studies on peripheral blood stem cell transplant for allogenic donors. And this then started the trend for allogenic transplant using peripheral blood stem cell transplant. And of course, cord blood transplant at that time was again gaining some recognition, although it took about 10 or 15 years before we started actually doing some of these. So the first randomized trial comparing peripheral blood stem cells to bone marrow was published in 2001. Here the patients were randomized. This is HLA identical sibling in your left panel to bone marrow compared to peripheral blood as a graft source. And what you can see is this results in better overall survival. And the reason is the engraftment is quicker, and that results in lower non-relapse mortality and better outcome, certainly in matched sibling donors. And certainly at most places, including at our center, for matched sibling donors, bone marrow, for matched sibling donors, peripheral blood stem cell transplant remains standard of care. Same thing was repeated in unrelated donor transplant. Actually, the results were not different. So as of today, centers use this differentially. Some use peripheral blood, some use bone marrow. And a lot of this now is dictated by the registry as to what the donor would give, whether the donor would be willing to give bone marrow or not. And there is some hesitation on part of donors to give bone marrow. But for what it is worth, the engraftment was quicker with peripheral blood stem cells. Acute graft versus host disease rate was same. Remember that peripheral blood stem cells contain 1 log more T cells. They have a higher dose of stem cells, but they also have 1 log more T cells. The higher dose of stem cell leads to faster engraftment. However, the higher there is a worry that higher T cell dose may result in higher graft versus host disease. At least for acute graft versus host disease, we don't see a difference. However, for chronic GVH, it is higher. And certainly there is a trend, at least in US and certainly at our center, for benign diseases where you don't need graft versus leukemia effect, because the other effect of or other belief is that higher T cell dose may result in better graft versus leukemia effect. For benign diseases, you don't need this. So at least in our center, for somebody with aplastic anemia, whether the person is having a unrelated or a match-related donor transplant, we would use bone marrow, mainly to prevent chronic graft versus host disease and improve long-term outcomes. We recently looked at peripheral blood versus bone marrow in haploidentical transplant. And certainly the outcomes were similar, but GVHD and particularly steroid refractory GVHD was higher in peripheral blood, and chronic GVHD, again, needing steroids, was higher with peripheral blood. So again, if we can, for haploidentical, we choose bone marrow, although there are pros and cons of this, and it is completely dependent on the doctor who is taking care of the patient. A word about cord blood. It is easily available. It's a waste product. Cord bloods are naive, so mismatches will be well tolerated, and therefore can, because the cells are naive, you have low incidence of graft versus host disease, but in return, we use mismatched cords. So eventually the GVHD rate goes up as well because they are mainly mismatched cord. The big disadvantage is that there is low stem cell dose and there is slow engraftment, and there is poor immune recovery. So the neutrophil engraftment can be almost 10 days later with cord as opposed to, say, your bone marrow or peripheral blood. And lately, with the development and appearance of haplotransplant, cord has become less and less, is being used less and less. And certainly, it has been limited to some specialized centers and pediatric age group. So switching gears, and development of newer conditioning regimen. Here we are doing transplants for patients with acute leukemia, chronic myeloid leukemia, and cancers. So the first question that arose in those days was, how does allogeneic transplant cure cancer? And it was felt that high-dose chemotherapy really gets rid of the tumor. And because you don't have a clean graft, you take cells or donor stem cells from a matching donor and salvage the patient for lethal chemoradiation. So in this view, it was felt that it was only the chemotherapy, the high-dose chemotherapy, that had some role to play in cure of cancer or leukemia. But as early as 1957, and this was one of the spin-off of atomic age and radiation therapy, this physicians, this scientist, Barnes and Lutet, who worked at Medical Research Council in England, doing some work on radiation research. In their mice studies, what they showed was, if the dose of radiation was insufficient to kill 100% of the leukemic cells, homologous or allogenic marrow might produce an immune reaction to destroy any surviving leukemic cells. So this was the first inkling that the graft that you give plays some role in killing the cancer. And then we looked at evidence, and there was these anecdotal reports. And this, some of you may have seen it also. So here was the report of a patient who had relapse of the disease, but patient developed graft versus host disease, and the leukemia went into remission. Something similar we do see these days in patients with myelofibrosis. If they have relapse disease, early relapse, you just stop the tacrolimus. They develop graft versus host disease and graft versus tumor reaction and go into remission. Secondly, when they looked at it, and this is data from Seattle, the relapse was lower in patients who have graft versus host disease. And here it is shown in the data from International Bone Marrow Transplant Registry. This curve shows probability of relapse with time. And what you see over here is the lowest relapse rate of about 10% was seen in patients who had acute and or chronic graft versus host disease. These are the patients who had lowest risk of relapse. And the highest risk of relapse was in patients who had identical twin transplant. If you think about it, identical twin gets a clean marrow. However, twin is genetically identical, so does not mount a graft versus tumor effect or graft versus leukemia effect, and you have high risk of relapse. Likewise, if you T-cell deplete completely, the relapse rate is very high. So this then begets the question, can you just rely on the immune effect of the graft to cure the cancer? Because most of the side effects related to transplant are due to the toxicity of the high-dose chemo and radiotherapy. Perhaps what clinched the deal was this paper, and I would urge all the fellows and residents in the audience to actually pull up this article and read it. This was a simple study by Hans Koop from Germany. They did transplant for patients with CML, and patients relapsed. So they took 3 patients, and they basically took blood from donor and infused it to patient who had relapsed, and all 3 patients achieved remission. It's a simple study, 3-patient study, but it proved a big principle that donor cells can cure leukemia. So that begets the question that maybe you can reduce the conditioning regimen, which is the source of all your maladies and toxicities, lower the regimen. And most people, what they did was use the half dose of conditioning regimen. So say busulfan dose, if it was 4 days regimen, people gave it only for 2 days. Melphalan was used certainly at our center at MD Anderson. That was shown to be lower intensity and reduced intensity. And in Seattle, they use lower dose of radiation, just 200 centigrade, rather than 1200 centigrade that we use for this. And the idea was that you give high doses of stem cells. What you will achieve is some engraftment, this mixed chimeric state, where there will be some recipient cells, there will be some leukemic cells, and there will be donor cells. And at some point, you could give donor leukocytes and eradicate this recipient, both normal cells and leukemic cells. And thus was born reduced intensity transplant. And the rest, as they say, is history. And here is the data now published about a decade ago, where outcomes of patients undergoing reduced intensity transplant in patients with AML on the left and MDS on the right. And what you can see, about 30 to 40% of the patients can be cured of their disease. Each of these curve refers to different age group. So whether the patient is younger or older than 65, you can get similar sort of outcome. So what that means is this was a big and huge step. That ceiling of 40 years for allogenic transplant was broken. Now you can do transplants even in older patients. And the oldest patient that I have transplanted is 78 years old. A 78-year-old pretty fit lady who had an allogenic transplant. And these days, routinely, age is not a barrier. So our new 40s is something like 70 or 75. Anybody over that age, we start worrying whether these people are transplant candidates or not. What this also illustrates are the flaws of this approach. Yes, 40% is great, but once you get something, you turn greedy and you want it even better. And most of us like this number to be, say, 80, 90%. And at the end of my talk, I will show you some data how we reach from this 40% to 89%, 80 or 90%. And basically, the challenge is the cause of failure is twofold. One is treatment-related mortality, which is about in a third of patients, and relapse, which is about another third of patients. So it's a rule of third. Third of the patients will die of treatment-related mortality, third of the patients with relapse, and third of the patients will be alive disease-free. What about myeloablative transplant? And just one slide to show that we made progress in myeloablative transplant as well. And here in this case, the busulfan preparation, oral busulfan was replaced by IV preparation of busulfan. This was made by Dr. Anderson at MD Anderson, no relation. And he prepared this IV busulfan, preparation of busulfan, and that he combined with fludarabine. And fludarabine combined with busulfan in the myeloablative doses, as you can see here, gave pretty good outcome in patients who were in remission. And this now has become a standard regimen used by most. So if you look at it today, the standard regimen, this is the data from CIBMTR from 2009 to 2019, myeloablative conditioning, 40% are Buflu, another 29% as Bucy, and again, 20% still use TBI. You move on to reduce intensity. Half dose Buflu is used by a quarter of patients. Fludarabine melphalan, again, this was done by Sergio, the first studies were done by Sergio Giralt at Anderson when I was a fellow. In my first year, this is what we used to do during fellowship. We would give fludarabine and melphalan 140 per meter square and give them cells from the donor. This is now used by a third of the patient. And of course, radiation, flu-cy TBI or flu TBI as developed in Seattle is used in another third of the patients. Again, as I alluded to, more and more older patients are being transplanted. And here is a number of 70-year-olds and 60 to 69. here is data from MD Anderson. So in 2005, when I joined MD Anderson again after a stint as residency and fellowship, moved from Baylor, we were doing about 15 patients per year who were older than 65. And the older patient transplants use has exploded. And we now do 5 times as many transplants in patients who are older than 65 than we used to about 15 years ago. Last year, we did 100 transplants in patients who are older than 65. And of course, that brings its own challenges, and I will address it at the last part of my talk. How do we get these older patients through transplant? That needs some rethinking, and we will talk about it at the end of my talk. Finally, antiviral medicine. We moved from ganciclovir treatment to prophylactic or preemptive ganciclovir therapy, where you detect blood infection and treat them preemptively, or give them ganciclovir prophylaxis. With this strategy, the CMV pneumonia has decreased from 13 to 2%. But I think letermovir has made a huge difference. With these drugs, we hardly ever see any CMV. And really, I can count number of CMV pneumonia cases on my finger in last 10 years, and would be less than 5 that I've seen. Antifungals, we now have very potent azoles, and certainly aspergillus and and even mucor can be treated. And here is the data on use of antifungal as prophylaxis. And this was a randomized trial comparing fluconazole to placebo. It reduced the incidence of candida. And of course, now many of centers like ours have started using voriconazole or even posaconazole, rightly or wrongly, to prevent further fungal infection. So that has had another major effect. And of course, newer antimicrobials are useful. A word about growth factors. We do have GCSF, but what about platelets? And L-trombopag has been licensed for use in aplastic anemia and also in patients with ITP. So we used it and compared it to placebo. Unfortunately, this was a small study, although randomized. So for an endpoint of recovery of platelet count more than 30, there wasn't much difference, although this was because the study was underpowered. However, for platelet count more than 50, so there were 21% of patients on L-trombopag achieved platelet count more than 50 compared to 0 on placebo. So if you have a patient who has delayed platelet engraftment, in this study, we started L-trombopag at day 35, and you certainly can have some patients respond, as you can see over time. Earliest response you see, sometimes it takes almost 8 weeks before you see response. And it's something like aplastic anemia, where you have to wait for 3 months to see the response. How about using L-trombopag along with GCSF? And we did that in this study, and which is awaiting publication. Really, what we saw was the median time to platelet engraftment was faster. This was in patients who underwent haplotransplant with bone marrow graft, and median time was improved by 4 days. And cumulative incidence of platelet engraftment also at day was also better, 81% compared to 63%. And we had some reduction in platelet transfusion, although this was not significant. So this again, the company has not tried to develop this drug further, but it's something that one can think about, although there is not much research interest in this. What about graft versus host disease? And here is a simple cartoon of what causes graft versus host disease. So chemotherapy or radiation damages the tissue. This tissue injury results in T cell activation and release of cytokines, which further activate T cells. And these cytokines then damage, and T cells activated damage normal tissue leading to graft versus host disease. And this loop goes on and on. So if you want to stop this loop, you can affect the cytokines. And one way to have antibody against this cytokine. However, these are redundant. And probably one of the best ways to do it is to block the receptor that these cytokines act by. And these cytokines act by this JAK-STAT pathway. So if you were to use a JAK inhibitor and block this pathway, you could improve graft versus host disease. And ruxolitinib, which is a JAK1/2 inhibitor, licensed for myelofibrosis, and now also for graft versus host disease, was first tested in steroid refractory graft versus host disease. And the response rate almost double, 62% versus 39%, odds ratio of 2.6. And this resulted in a better survival. And certainly these days, we have new drugs to treat chronic graft versus host disease, ruxolitinib, ibrutinib, and more recently licensed belumosudil. So the field has a lot more things for graft versus host disease than we used to. How about prevention? This, I think, was probably one of the most path-breaking idea. So your T cells are activated by antigen-presenting cells. And the idea is that they proliferate. And if you kill them, and in this particular study, they use cyclophosphamide on day 3 and 4, you would kill the alloreactive cells. You would save some non-alloreactive cells. And of course, cyclophosphamide doesn't act on stem cells. So you will see engraftment. This concept was used in haploidentical transplantation by Johns Hopkins group. And here is their initial study and initial regimen. And you had about 40% of the patients surviving long term. And this has completely changed the field and made haplotransplant available to most places, because it is, at the end of the day, very, very simple concept. And then this was looked at in CIBMTR, where haplo had similar outcome with unrelated donor. One caveat here is that unrelated donor had tacrolimus, whereas haplo PTCy, and there are some benefits of PTCy. A randomized trial is underway, and that would show give the answer. But when we looked at, compared the patients who had PTCy and had unrelated donor transplants versus haploidentical transplant, we found that unrelated did better. So it may be that PTCy GVHD prophylaxis may be good. But be it as it may, the use of haplo is increasing as the time goes by. In this curve, code is going down, and there's sort of plateau otherwise in number of transplants being done. Last 5 minutes, I will talk about future graft source. So there was some work done on expanded code, and we had quite a few studies, including in high impact publications like New England Journal and Blood, where we expanded the cord and reduced engraftment to, say, 14 days. However, again, with the advent of haplo, these studies have not moved further. At the ASH meeting, T cell depletion is making a comeback, and there's the engineered graft where they give T depleted graft, and then they give regulatory T cells and T cells to fight infection. And this is an area of active research. One of the problems I alluded to, and when you compare myeloablative and reduced intensity conditioning regimen, reduced intensity has a lower non-relapse mortality, but higher relapse rate, resulting in similar outcome to myeloablative regimen. So really what you need is a regimen that would reduce mortality, would act like would have a lower toxicity myeloablative regimen with low mortality, but will also lower relapse rate. And this is a conventional way of doing busulfan and fludarabine. You give 4-over and you give fludarabine combined with busulfan. We hit upon a simple idea. Who says you have to do it over 4 days? Why don't you give it for a 2-week period? And so what we did was we took a third of the dose of busulfan, gave it as an outpatient, and gave the total myeloablative dose. And this was given to patients as old as 75. And in the early studies, we compared it to a standard busulfan reduced intensity regimen there, and we saw better survival. This is a retrospective comparison, which was mainly related to reduction in the relapse rate. So we took this further and said, if 2-week interval is better, can you use 3-week interval? And 1 dose here, 1 dose of busulfan here, and come in with cells. And then we gave PTCy to these patients. And what you see over here is this is more intense myeloablative regimen than Bucy or Buflu. And 2/3 dose of reduced intensity regimen is given here. And about 1/3 dose of myeloablative is given here. And to reduce relapse, you can add various agents as listed over here. And this is over 6 or 7 protocols and multiple publications later. Here is the bottom line. We looked at 446 patients treated between 2016 and February 2021. We have 1-year survival of 80%, median age is 58, and interquartile range is 48 to 65. So 1/4 of the patients are older than 65. Non-relapse mortality is 12%, and the relapse rate at 2 years is 25%, and 1 year is 16%. So certainly this is an effective strategy. There was no difference between older and younger, and we are further continuing the study. And the next generation of study, we have added sorafenib, because who says that you have to use these drugs only with the induction therapy or just as single agent? Why not add to the transplant regimen? And at this ASH meeting, we showed that dose of 400 milligrams BID was chosen as a phase 2 dose. And we treated 24 patients in phase 1, and progression-free survival at 1 year was 89%. Same thing, you can add venetoclax to this. And in this regimen, Buflu-clad venetoclax, we see that 1 year survival of 84%. You know, AZA venetoclax is very effective. Venetoclax at our institution is combined with everything, and we have used it with transplant. And we again see very good survival data. So this is another thing for future, and we have further studies underway to sort this out more. One big area for the future is maintenance therapy. Here was a negative study from our center with using azacitidine, but here is a positive study from using sorafenib from Germany, where maintenance sorafenib for 2 years improved survival in patients with FLT3 positive disease. So further work needs to be done. Finally, as I said, we need to design transplant for older patients. So they need, they are frail, so they need, physical therapy, occupational therapy, need prehab. They have geriatric syndromes. They cannot tolerate drugs as well, and you need to take care of their polypharmacy. They need to take care of their hypertension, diabetes. They cannot tolerate fluid as much. You need to be careful. What you do for older patients needs to be different from what you do for younger patients. And we started the so-called enhanced recovery multidisciplinary program. And we saw that using this, we improved our survival by reducing the non-relapse mortality in patients who are older than 65. And this manuscript is again awaiting publications. Finally, in supportive care, cell therapy for supportive care. So BK virus is a major problem now with PTCy. So one could develop T cells against virus like BK virus. And what you can see is you can reduce the viral titer. And as shown in this paper, this was a study from Katie Rizwani and Amanda Olson. And what you see is you have a response rate about 70% to BK-CTLs. But this probably is the most important one, and that is using JC virus, in a very aggressive disease like PML, progressive multifocal leukoencephalopathy. Here, after using BK-specific CTLs, this enhancement you see goes down, 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 and down on day 58. Here is again this is gadolinium enhanced scan, and again you see no enhancement going forward. So this is a proof of concept, and details need to be worked out. Another thing for future, if you can do mismatch related donor, this study from CIBMTR shows you can do mismatch unrelated donor. And 40% of the patients in this study were 4 to 6 out of 8 match. And this is truly haploidentical, if you will, unrelated donor, although it's not the same haplotype. It is 4 out of 6 match unrelated donor. Lastly, there are newer diseases. Here is a randomized trial using autologous transplant versus standard therapy for scleroderma, resulting in fantastic outcomes. And here we have a randomized trial now ongoing nationally in patients with multiple sclerosis based on this fantastic phase 2 results, where very low relapse rate, no MRI event, 90% of the patient in this phase 2 study, which led to the phase 3 trial for multiple sclerosis with autologous transplant using beam conditioning. Lastly, I will leave this for our president, Dr. Majel, who is coming after me. But one big area is development of gene therapy for sickle cell disease and thalassemia. Here is development of a specific beta gene, which has high hemoglobin F, and the cells are ex vivo transduced with this gene, and after myeloablative busulfan, they are given to patients with thalassemia or sickle cell disease. And as you can see, there is high hemoglobin F here in thalassemia patient. Here in the sickle cell disease, the level of hemoglobin F is quite high with suppressed sickling crisis. And this is another study using a different technology. Lastly, and this I'm setting stage for Dr. Majel, immunotherapy is changing cancer landscape. It was a breakthrough year in cancer immunotherapy, and Jim Allison, very proud that he got Nobel Prize for checkpoint, his work on checkpoint inhibitors. And immunotherapy is a big thing for cancer treatment. And immune effector cell therapy of CAR T, CAR NK, T cell receptor therapy is a big thing happening. And as you can see, we have now treated 439 patients at MD Anderson as of February 2021. We have 61 protocols and from 23 sponsors, and various targets are used, not just hematological malignancies, but in solid tumors. And hopefully some of these targets will bear fruition, and Dr. Majel will talk more about it. Thank you.
Thank you, sir, for a very nice overview of the evolution as well as the developments in the field of stem cell transplantation. It was very nice to hear you. So we have 5 minutes for some practical questions. First, we have, I think, all the panelists, Dr. Chepsi, Dr. Mobin. So let me ask one question first. So from a practical point of view, in your practice, if you have a MUD 9x10 donor versus haplo, so what would be your choice of selection?
Yeah,
I think we personally still use haplo. Now you ask different people, people will give different answers. We would use haplo because even for us it is cheaper, and I'm sure that applies more to you in India. It is quicker, and existing results are not different. Now, if I had some person who has got antibodies against haplo, the other haplotype, that is one place I would go with 9 on 10. And although I have not done any 6 or 8 out of 10, but 4 or 6 out of 8, but that's where I would use the donor, because when you get graft failure in somebody with high antibody titer, it's a problem.
Thank you, sir. So Chepsi, Mobin, Rohan.
Can I just ask a question? This, Dr. Uday, on your experience, this use of plerixafor to support a poor graft harvest. So why don't we resort to bone marrow in autologous to collect more cells, and why do we have to use plerixafor? Was it done in the past, or it is not recommended?
So before plerixafor, that's what we used to do. The part of the problem is when you have difficulty in mobilization, that means that patient's stem cell pool is low. So even with bone marrow, you're going to have problems. But that's what we used to do. So if plerixafor is too expensive, you don't have to. You can just do bone marrow. Keeping it in mind that these patients, whether you use plerixafor or whether you use 10 days of GCSF collection, which is saying the extreme, which we don't do, but sometimes you take 4, 5, 6 days, people go on. That is a poor quality of graft. So you may get the number, but you may not get a good engraftment. So I think the thing to keep that in mind is even with bone marrow, you may have poor engraftment. Second thing you can do is always, sometimes, patients have cough, cold, and they don't mobilize very well. So what we have done is we have remobilized them after giving them a couple of weeks with just GCSF again, or chemo GCSF. That has also helped. So there are several options. One is remobilization. Second is chemo and mobilization. Third is plerixafor, and fourth one is bone marrow. And fifth one, of course, if all those fails, then allotransplant.
Thank you. Thanks.
So one question that I have is with increasing the age of the patients undergoing allogenic transplants, have you observed any increase in the complications or any newer complications which were not being seen earlier?
2 or 3. First one is fluid overload and heart failure. So you take patients with normal ejection fraction and you give them whatever 100 cc or 125 or whatever you do with your younger patient, 84 cc an hour, that patient is going to get flooding. And so CHF is a big issue because they cannot deal with fluid. So we need to rethink that approach. In fact, one of the major, and it is so hard to change practice. It is more hard for us where we have a very large program, so we have too many providers. It may be easier in a smaller program where your law is the law of the land. Things will change. So that is one thing. Second thing, and this is again a big issue. You and I, if you are immobilized for say a month, you will survive. Your 40-year-old or 30-year-old will regain quickly because the muscle mass is there, their stamina is there. Older patients, and you will see this with a lot of other conditions. Once an older person enters hospital, if they stay beyond a certain period, they become so deconditioned. If you don't take extra efforts, what you will be dealing with is problem of mobility. So we want to proactively deal with it. And every patient older than 65 starts on a physical therapy program. They have an occupational therapy program, whereas, which helps them with activity of daily living. Now think about it. If you are at home, at least you will get out to go to the restroom. You'll get out to eat your meals, and you will, go and take few things. When you are in hospital, you ask the nurse for everything. And that dependence, I think so. That frailty is a big issue, and we need to deal with it very aggressively. And then, of course, the drugs. And this is a major thing. And this is a true story. So you know, the typical, the practice used to be that your patient is getting blood products. So you pre-med them. So in our hospital, this is how it used to work. So they have labs done at 4 or 5 o'clock. So nurses, before their shift gets over at 7 o'clock, they will give them blood products, because you know you have a parameters set in. So they will give them Benadryl, and there is nothing that knocks off anybody more than a Benadryl, an older person. 12.5 or 25 milligram of Benadryl, the person is knocked out. So in the morning when I go for a round, they are no good to me. They don't talk. Some of them can alter their diminished brain capacity. If you think about it. And finally, you know, your hospital staff, occupational therapy, physical therapy, nutritionists, they all come during the morning hours. So they don't participate in any activity. So drug management is hugely important for older patients. What you got away with younger patients, you won't get away with older patients.
Sir, regarding the dose of melphalan, 200 mg bar 140 mg, that's the first question. I want your comments on that. And where tandem transplant stands now in deletion 17p myeloma, high-risk myeloma.
Okay, so I presume the question is relating to autologous transplant and myeloma and not allotransplant.
Yes, sir. Yes, sir.
So I think, as you very well know, that there was a French study which showed benefit of tandem over the single auto transplant. That was some time ago. And since then, the field of myeloma has exploded. There are so many new treatments available for these patients that transplant, although it is still remains very essential, and every patient of ours gets a transplant with high-dose melphalan, 200 milligram per meter square. Tandem transplant really is not done, at least certainly at our place. We wait before the relapse and give it as a salvage if need be, if we don't have any other options. Regarding the dose of melphalan, typically we use 200 milligram per meter square. But in older patients, sometimes even in renal failure, people have used regular doses, but we sometimes cut it down to 140 milligram per meter square. Perhaps we are losing efficacy, I don't know, but it certainly brings down toxicity, because somebody who's 76-year-old, little bit frail, may not tolerate 200 milligram per meter square. So those are the judgment calls we do. For a younger patient with high-risk disease, we had a randomized trial where we compared high-dose melphalan to busulfan and melphalan. And certainly we had benefit in event-free survival. So at least for high risk, if they are young, we go with that regimen, BUMEL. So that is busulfan AUC 20,000, or your standard dose of busulfan, and melphalan 140 per meter square.
Thank you, sir. So since we are running short of time, there are a few questions in the chat box, but since we are short of time, I think we need to wind up. So thank you very much, sir, for the very, very nice illustration of the events. Thank you very much. And thank you all the panelists. Over to you, Dr. Shinto.
Thank you. Bye-bye.
Thank you, Dr. Popat, for such a lucid talk. Thank you so much, sir. So I thank the moderator, Dr. Chandran, sir, and other panelists, Dr. Chepsi, Dr. Mohan, and Dr.